Bismillahirrahmanirrahim. This is the second presentation for the imaging of the shoulder. We have discussed Bankart lesion, and we said that in Bankart it's always the anterior labrum which is involved, and the detachment of the anterior labrum is called Bankart. If it is involving bony part of the glenoid rim or involving heel sacs, it will be osseous. If it is involving only the inferior glenohumeral ligament, it's called the fibrous Bankart. But other lesions are usually seen because we said that anterior dislocation of the shoulder and anterior instability is the main cause for the shoulder instability. Anterior stability forms 95% of all instabilities. And we said about Bankart, but we said we now know that there are some other lesions involving also the anterior labral. So Bankart variants are other anterior labral tears based on the type of detachment of the labrum and the capsule. That means if the anterior labral tear is associated with periosteal sleeve avulsion, it's called anterior labral periosteal sleeve avulsion. Or if there is associated avulsion of the glenohumeral ligament, this will be humeral avulsion of glenohumeral ligament, or Hagel. And if it is only the cartilage which is involved, it will be called GLAD, or gleno-labral articular disruption. So we now have burst disease when the periosteum is intact and only part of the labrum is involved. The periosteum is intact. Here there is periosteal sleeve avulsion. Here there is avulsion of the ligament itself from the humerus, and this is most common, Hagel. And gleno-labral articular disruption means involving only the cartilage, and this is called the GLAD. The burst lesion. In burst lesion, we have non-displaced avulsed anterior labrum. Non-displaced. The labrum is still there, not displaced. It is, as we said, a Bankart variant, means involving the anterior labrum, and it is seen as non-displaced avulsion without any involvement of the periosteum here. The periosteum is intact. So it is avulsion, partial avulsion, we can say like that, non-displaced partial avulsion of the anterior labrum. And here we just get the avulsion, but the bone itself is intact. This is axial T1 orthography with fat suppression showing undisplaced avulsed anterior labrum or anterior-inferior labrum with medial stripping of an intact scapular periosteum. The periosteum is minimally stripped. Now Bankart, if involved the labrum and the periosteum, it will be the anterior labral periosteal sleeve avulsion. Anterior labral periosteal sleeve avulsion. The torn anterior-inferior labrum is displaced. In the last one, in the birth, it was not displaced. It is in the same alignment. This is birth. If it is displaced, that means there is periosteal sleeve avulsion. Part of the periosteum is avulsed, and the labrum is seen away from its site. The torn anterior-inferior labrum remains attached but displaced. So if it is displaced, it is called anterior periosteal sleeve avulsion, and if it is not displaced, it's called Birth's injury. And both are involving the anterior labrum. Anterior labrum in its place, no displacement, is Birth's. Anterior labrum with displacement, that means periosteum is avulsed, is called the anterior labral periosteal sleeve avulsion. The third one is the glad, and here there is gleno-labral. Gleno means glenoid, labral articular disruption. That means the labrum is partly disrupted and the cartilaginous layer is showing a pit, small pit. Here it is. Cartilage is partly involved and the labrum is still in its place. It's a partial tear of the anterior labrum and adjacent cartilage. So we can go back again and see what is there. Birth's disease, Birth's lesion is undisplaced anterior inferior labral tear. Anterior periosteal sleeve avulsion is displaced anterior inferior labral tear. Glad, there is no displacement and there is definite articular cartilage lesion. This is birth, no displacement. This is periosteal sleeve avulsion. It is displaced. And this one is non-displaced again like birth, but involving the articular surface. So if it is involving articular surface, it is glad, gleno-labral, means involvement of both the labrum and the glenoid. Gleno-labral is glad. If it is not involving the articular surface and only involving the margin of the capsule, this is birth. So and the labrum here is not displaced but disrupted but not displaced. And the third one is the displaced, which is famous. It's the displaced labrum due to periosteal sleeve avulsion. Periosteal sleeve avulsion. As we said, in glad, there is no displacement. The labrum is still there, but disrupted. And if you follow the articular surface here, the articular surface is showing partial lesion, partial tear, sticking with the labrum, and it is well seen by arthrography. So anteroinferior labral tear, which is held in place, no displacement, and involving part of the articular cartilage, glenoid articular cartilage, is called glad. Attached fragment of the adjacent articular cartilage is that one. The arrow is pointing, and it's held in place with the torn labrum. We can repeat again because this is important. Birth disease is anterior inferior labral tear, without displacement. If there is displacement, that means the periosteum is sleeved. If there is articular cartilage involvement, this is called glad, and in glad there is no displacement. There is no displacement in glad, there is no displacement in pars, but only there is displacement in periosteal sleeve avulsion. So this one only labrum, this one labrum plus part of the cartilage, but both are not undisplaced, and the only displaced is that one, periosteal sleeve. Again, this is pars, it's only antero-inferior labral tear without displacement. And this one, this is displaced labral tear, should be here, comes down. That means that periosteum is sleeved, or the periosteum is avulsed. And the third is the glad, which is displaced, not displaced, but involve part of the cartilage. And here is the image. It's involving part of the cartilage, that gray part, and the labrum is black. So this is glad, or the gleno-labral tear. Now, the last one in Bankart lesions, which are anterior instability due to usually dislocation or subluxation, it is humeral avulsion of the glenohumeral ligament. Hagel. Humeral avulsion of the glenohumeral ligament. Usually the capsule will be big like that, edematous, as you see, and this is the greater tuberosity, may be contused, is seen showing hyperintensity. If there is part of the bone involved, humeral bone, it's called B. Hagel. So we have Hagel and we have B. Hagel. The inferior axillary pouch, if it is torn from the humeral attachment, is called Hagel, and if there is bone involvement with it, there is it's called B. Hagel or bone Hagel. To read about this glenohumeral ligament injury, the glenohumeral ligament injury, the most important is the anterior part, which is involved in anterior and dislocations and subluxation. So anterior glenohumeral instability can involve the glenohumeral ligament, and we said before that anterior glenohumeral instability means all what is going on after as sequelae of anterior and inferior dislocation. The inferior glenohumeral ligament consists of an anterior band, posterior band, and an interposed axillary pouch. So injuries to the anterior band are more likely to be associated with the with the clinically evident instability, because once there is dislocation or subluxation anteriorly, the most important stabilizer is the anterior band. The anterior band will be injured. The humeral avulsion of the glenohumeral ligament, or the Hagel, is an avulsion of the inferior glenohumeral ligament, the anterior band, or near its humeral attachment. In 20% of cases, you can find medial humeral avulsion, bony fracture, bone part fracture, and that's in this case we call B. Hagel. And rarely we can get inferior glenohumeral ligament cut anterior and posterior, and in this case it will be as a flail part, and it's called floating avulsion of the inferior glenohumeral ligament. So to conclude, the inferior glenohumeral ligament is the most important one, because it is the one supporting the shoulder and preventing downward or anterior dislocation or subluxation. There is an anterior band which is very tough. This is the most important. Injuries of the inferior glenohumeral ligament, mainly the anterior band, is called Hagel, glenohumeral avulsion, or humeral avulsion of the glenohumeral ligament. If it involves bone, with bone fracture, it's called B. Hagel. If the anterior band and posterior band of the capsule both are cut or both are torn and the capsule is avulsed, this is called the floating avulsion of the inferior glenohumeral ligament. Now this represents another condition similar to Hagel, but it is not involving the humeral attachment. It is in the middle of the capsule. In the middle of the capsule, with seeping of the bursal fluid, it's called ligament substance tear of the inferior glenohumeral ligament, usually after anterior dislocation or severe subluxation, but no Bankart or Hagel. This is not Bankart and not Hagel. This is just tear of the inferior glenohumeral ligament. To differentiate this from the previous one, the Hagel or humeral avulsion, it is at this region, while inferior glenoid inferior glenohumeral ligament tear, it is in the mid substance. One at the attachment and one at the mid substance. We go posterior. Posterior is related to posterior. So if there is posterior calcification, this is called Bennett lesion, like this one, or like this one, or like this one. These are called Bennett lesion. And in posterior dislocation, the reverse of anterior dislocation will occur. So usually you have Hill-Sachs erosion, and we have Bankart, as we said, anterior labrum. Here the process will be at the posterior labrum, and the as in this case, this is the glenoid and this is the humeral head, and the impaction is here, so the impaction is posterior. So posterior impaction will form labral lesion and Bankart lesion, reverse Bankart lesion. Instead of being posterolateral, it will be anteromedial. This occurs in posterior dislocation, the reverse of Bankart. Bankart involve the anterior labrum, posterior dislocation involve the posterior labrum. Here it is, we have posterior dislocation, and in posterior dislocation we have the, instead of having Hill-Sachs posterolateral, we have it medially anteriorly or anteromedial, and we have here the osseous reversed Bankart. This is the posterior part of the glenoid where there is a small fracture. So it is reverse of Bankart, which should, Bankart is anterior, this is posterior, and this is the Hill-Sachs, which is the medial anterior or anteromedial. So reverse Hill-Sachs means anteromedial, reverse Bankart means posterior glenoid rim, and the lesion will involve the posterior labrum. Posterior labral tear, here it is. This is posterior labral tear, posterior labral tear, secondary to posterior dislocation. or what we call reverse bankard. Now going to slab lesion. Slab lesion means that the labrum is affected along or at its superior aspect, superior labral. The word slab means superior labral tear. Superior labral tear involving both anterior and posterior parts. Superior labral tear involving both anterior and posterior parts. And we know before that the biceps tendon is attached to the glenoid and have attachment to the superior labrum, both anterior and posterior. So repetitive traction on the biceps will result in slab. It may be only degenerated. It may be, which is the most common of all slab lesions, may be with avulsed superior labrum involving the attachment of the long head of biceps, thus detaching this from the glenoid. The long head of biceps, as we said, have two attachments, one to the glenoid and one to the labrum. So if the torn superior labrum is avulsed with avulsion of the attached biceps from the glenoid, this is the second type. So the first type is only labral, the second type is labral and biceptal or biceps, and number 3, that there is displacement of the whole thing. The biceps is intact, but the labral tear is displaced. Number 4 is that both are involved. So to summarize, slab lesion number 1 is a tear of the superior labrum. Slab lesion number 2 is a tear of the superior labrum with involvement of the biceps tendon, attachment of the glenoid. Number 3 is inferior displacement. Both the first two are without apparent displacement, but once displacement there is of the labrum only. This is a bucket handle tear. If displaced and involve the long head of biceps attachment, this is number 4. 1 and 2 without displacement, 3 and 4 with displacement and bucket handle. 1 and 2 are labrum and 2 is labrum plus tendon. 3 is labrum and 4 is labrum plus tendon. So if you want to study this is a tendon and this is a labrum. This is the superior labrum, and here we start avulsion from the origin of the attachment of the biceps. If the classic slab number 2, which is involving labrum and involved attachment of the tendon of the biceps from the glenoid plus any other labral tear, this is called extended slab. So extended slab is a number 2 slab which is involvement of the labrum, superior labrum, and the involvement of the attachment of the long head of the tendon of the biceps into the glenoid, plus any other labral tear, anterior, posterior, inferior tear, all constitute what we call extended slab lesions. And according to the lesion added to the original slab, we have different types. For example, if the anterior labrum is involved beside the superior labrum, which is the original slab, it's called type 4. If there is flap tear of the superior labrum, it's called type 5, type 6. And if there is involvement of the capsule, inferior glenohumeral ligament, it's called type 7. And if the posterior labrum is involved, which is very rare, it's called type 8, and so on. Superior lateral region of the rotator interval receives insertion from the superior glenohumeral ligament, the coracohumeral ligament, and the subscapularis tendon. That is the rotator, the superior lateral part of the rotator cuff. This is acromion, and this is the region of the supraspinatus, and here is the subscapularis region, and this is the region of the infraspinatus, teres minor, and here is the region of the infraspinatus, and here should be the region of the biceps tendon. Now, hidden means difficult to visualize at arthroscopy, and lesion of the superior glenohumeral ligament, which is here, or the coracohumeral ligament between the coracoid and the humerus, usually occur as biceps instability. So this is the region of the biceps, and once you get any abnormal signal here at the biceps tendon pathway, this indicates that the superior lateral region of the rotator cuff, superior lateral region of the rotator cuff anterior to the supraspinatus and above the subscapularis, there is something wrong there. There is abnormal intensity while the biceps tendon is here. There is abnormal intensity. This means that there is something wrong with any of the three. Usually it is the coracohumeral ligament. Usually it is the coracohumeral ligament, the CHL, which is involved in such cases. This is called hidden rotator cuff or hidden rotator interval lesion, and usually hidden. It is hidden to the arthroscope. It's difficult to visualize by the arthroscope. Here there is torn attachment of the superior coracohumeral ligament. As we said, this is the region of the subscapularis tendon. This is the region of the supraspinatus tendon, infraspinatus tendon, and teres minor tendon. So this is the region of the biceps, and you find high signal intensity in this region. That means that this is biceps tendon tear. Here the biceps is dislocated. It's not in its place. It is dislocated. Here it is dislocated anteriorly. Fluid signal intensity in T2 weighted image within the superior labrum of the biceps labral complex. It is either due to degeneration or detachment or superior labral anterior cuff lesion, or anterior to posterior, that means classic slab, In other words, without memorizing all of this, now fluid intensity within the superior labrum at the region of the biceps complex denotes a lesion of the superior labrum and attached part of the biceps tendon. It could be a degenerative fraying, it could be detachment, could be classic slap, could be anterior cuff lesion, could be peeling back, or bucket handle tear of the superior labrum or its surrounding, extending to the biceps. Now going to the osseous structures. We know that the acromioclavicular joint, there is sometimes abnormal shape or abnormal configuration or osteoarthritis or bony spur, and this is the supraspinatus muscle and tendon. So compression of the supraspinatus and subacromial bursa, this area between the humeral head and the coracoacromial articulation, depends on the shape of the acromion. It could be extrinsic, like osteoarthritis, or os acromial, part of the non-fused ossific center, apophysis, unfused apophysis with the anterior acromion, or it could be due to instability due to athletes, due to sports. So we have subacromial impingement. The main reason could be will be the osteoarthritis, but congenital lesions also are there. Slap or the posterior or the superior labral tear and bony damage as occurring in athletes constitutes what's called as the posterior-superior glenoid impingement. Here you get synovitis, labral fraying, sclerosis, cystic changes, all starting from the superior and the related part of the bone of the humeral head, superior labral and related part of the humeral head. We can get an anterior acromial spur, or what we have mentioned about also the os acromial, or the shape of the acromion may be curved down or hooked, or the slope is abnormal, or there is hypertrophic bone as in osteoarthritis. Any of this change of shape, change of slope, or change of morphology can result in impingement. The impingement can be classified into stage 1 when we get tendon edema and hemorrhage, stage 2 fibrosis, stage 3 tear, usually associated with bony spur. Here we have the supraspinatus tendon with partial tear along the bursal surface is due to impingement. So impingement results in tear, but usually partial and usually bursal, not to the articular, to the joint side, no, but it is towards the subacromial or subdeltoid bursa side. That's why we said dorsal surface partial tear. This is the tear. Here it is. This is an impingement without tear. Here we get the supraspinatus and tendon, and this is the abnormality, slope curved down with new bone but no tear. In chronic impingement like this, osteoarthritic, we have tendinosis, means more fluid around the tendon, more fluid around the tendon, with the swelling of the tendon and hyperintensity. This is acromioclavicular osteoarthritis causing impingement. Another case of osteoarthritis, not acromioclavicular, but osteoarthritis of the shoulder joint itself. And if we want to describe this, it is so simple. There is marginal osteophytes, there is subcortical pseudocysts, there is definite narrowing of the joint with resorption of the cartilage in between, and there is large capsule following the new bone formation here, and the sclerosis seen by this low intensity. So all these are the components for osteoarthritis of the shoulder joint. And of course all of us know about that. This is the AVN, or avascular necrosis of the head. Here we get sometimes we get this appearance. This is cartilage, this is bone, so it's called osteochondral pits, osteochondral lesion. This is a greater tuberosity fracture, and here there is bone edema due to fracture of the greater tuberosity. In rheumatoid arthritis, definitely the synovium will be markedly thickened. Definitely the synovium is markedly thickened, lobulated like that, and pannus may erode, and rice bodies within the bursa can be seen. This is the appearance of rheumatoid. So we have thickened synovium with bossy outline, with bone erosions, narrowing of the joint, subluxation, and rice bodies. These are the typical components of the rheumatoid. Here, if you look at this, and there is some bony changes here, the pattern of calcifications here are amorphous. They are not patchy as new bone formation elsewhere, but it is, as you see, linear, curved, mottling. This characteristic of chondroid matrix, and this proved to be osteochondroma going to chondrosarcoma. So this is a chondrosarcoma. Here we have large cyst, we have a large cyst extending into suprascapular, and distally into the inferior to the glenoid, here and there. This is the cyst. And when we check the labrum, superiorly there is break, there is tear of the superior labrum in this one, and posteriorly there is another tear. This is anterior, this is posterior, there is another tear here. So there is torn posterior labrum, and there is torn superior labrum, and the large cyst which is extending suprascapular and infraglenoid and around the joint. This is superior and posterior glenoid labral tear with large paralabral cyst. Large paralabral cyst, superior and posterior glenoid labral tear, and as a sequelae. Now here we can find that this is osteoarthritic, and we have some new bone formation around, and here these are the loose bodies around the joint. So this is an osteoarthritic joint with multiple loose bodies. This is called osteochondromatosis, but because it is not primary osteochondromatosis, it is due to osteoarthritis, we call it secondary synovial osteochondromatosis. Secondary synovial osteochondromatosis. Multiple loose bodies around an osteoarthritic shoulder. Now here where is the lesion? The lesion is superior. It is superior labral tear, and there is a line here representing partial tear of the infraspinatus. So partial tear of the infraspinatus, and superior labral tear, slap. What do you expect this to be? If you look here, it's a large joint effusion, and down there it is an area which is capacious. It's not conforming to the visual appearance of the capsule. It is due to detachment of this ligament from the humerus here, and so this is Hagel, typical Hagel. Hagel means humeral detachment of the humeral attachment of the glenohumeral ligament. Detachment of the humeral attachment of the glenohumeral ligament. Hagel, it is the, as we said, if it is involving bone, it is called the B-Hagel, and the top differential is Bankert, because Bankert lesion is an anterior labral tear, usually occurring with the dislocation and subluxation, which commonly 95% are anterior. What is this? Now here we find that we have the humerus with fracture, definite fracture humerus, but as we follow the ribs, we find here step deformities of the ribs, and there is air fluid level there. So this is fracture humerus, fracture ribs with hydropneumothorax. Now this one, if you look at the humeral head, you will find that the humeral head is superimposed on the glenoid, and all of us know that anterior dislocation is usually inferior, while posterior dislocation is usually superior. So this is typical appearance of posterior dislocation. Here it is, this is tangential, and this is the posterior dislocation, and here we get the reversed Bankert, the medial anterior bone erosion due to impaction with the glenoid here. Posterior dislocation, less common, it is only 5%. The humeral head lies superior to the glenoid. The trough sign is the compression fracture of the anterior humeral surface. It's called trough sign. So it is usually superimposed on the glenoid, like this one, and the trough sign is the erosion or fracture or avulsion of the anterior part of the humerus. This one is anterior dislocation. It is down and inferior and anterior. So downward displacement is usually anterior, upward and posterior displacement usually seen as superimposed on the glenoid. So what is this? It's not anterior, not posterior. This is downward. It's not anterior or posterior. This is the head, this is the humeral shaft, and this is the glenoid. It is neither anterior nor posterior. It is downward, and downward dislocation is called locatia erecta. Locatia erecta. Locatia erecta is the inferior dislocation. Inferior dislocation, it's very rare, and it is one of the strange positions you can get as dislocation. Of course, anterior dislocation, you have the anteroinferior lesion of labral tear and Bankert, and you have the heel sac deformity here. Osseous Bankert means avulsion of the glenoid rim, and heel sacs of the humerus. Any of them, either this one or that one or both, are sequelae of anterior dislocation plus the anterior labral tear. What do you expect here? This one is subluxated, and there is definite irregularities here and there. If you look at this, the greater tuberosity is irregular, the glenoid inferiorly is irregular, so you should suspect that the rotator cuff are disrupted. There is something wrong. So once you see subluxation, glenoid abnormality, or greater tuberosity abnormality, please think of rotator cuff tear. Here you get something strange. There is vanishing bone lesion here and there, and this is famous as Gorham. Gorham's disease is the massive osteolysis due to angiomatous or angiomatosis of the bone. It is the apparently there is rapid dissolution of bone. Usually there is sometimes history of trauma, but it is an idiopathic process. It is an idiopathic disease. Gorham's disease is massive osteolysis, or what we call vanishing bone disease. Gorham disease is called the vanishing bone disease. Here you get erosion of the distal clavicle and bone osteolysis of the humerus, of the proximal humerus. Gorham's disease. Massive osteolysis or vanishing bone disease. Other angiomatous disease syndromes are, Maffucci, Osler-Weber-Rindu, Klippel-Trenaunay disease, Kasabach disease, and Gorham disease. Maffucci is the multiple enchondromas and soft tissue hemangiomas. Osler is the fibromuscular dysplasia of vessels. Klippel-Trenaunay, the cutaneous hemangioma and varicose veins on soft tissue hypertrophy, or what we call it a giant limb with many vessels subcutaneously. And the Kasbach is the thrombocytopenia. And lastly, Gorham, we call it vanishing bone disease or disappearing bone disease. What are the causes of erosion of the distal clavicle? Rheumatoid, hyperpara are the two main. Of course, metastasis, but please consider also Gorham, because Gorham usually is not starting in one bone, starts one bone and then extend to other surrounding bones. It is an angiomatosis. Now what is this? We have expansile bone lesion of the right humerus with multiple septation, which is usually not seen in simple bone cyst, and the blowout or the ballooned bone limited by the epiphyseal plate is usually seen in aneurysmal bone cyst. But of course, you put also simple bone cyst as a differential diagnosis. So what is this? This is a supraspinatus tear. And what is this? This is the pectoralis major, and here it is dense. It is due to calcific tendinopathy of the pectoralis major. It's called pectoralis calcific tendinopathy. And what is this? This is infraspinatus atrophy due to denervation syndrome. So denervation syndrome can result in infraspinatus atrophy. So what is this? It's typical cyst, lytic lesion with what we call fallen fragment sign, fallen fragment, and pathological fracture. Here it is. So there is a pathological fracture, and this is what we call the fallen fragment sign, and this is typical for simple bone cyst. Which tear is this? This is the subscapularis tear. Subscapularis tear is usually seen as this. What happened here? This is superior liberal tear. Superior liberal tear, or what we call slap lesion. This is slap lesion. So what is this? Is disorganized, fragmented, distracted, dislocated joint? It is the famous Charcot or neuropathic joint of syringomyelia and diabetic neuropathy. Of course, trauma and osteoarthritis could result sometimes in such an appearance. Advanced lesions. Here there is muscular calcifications. This is called myositis ossificans. Myositis ossificans. See about this part also. This is myositis ossificans. What is this? This is a biceps, and this is biceps tendinitis. What is this? This is the site of the infraspinatus. This is infraspinatus muscle and tendon tear, hyperintensity within the infraspinatus muscle. What is this one? This is a greater tuberosity fracture. Greater tuberosity fracture. What is this? This is posterior and lateral, so it is a Hill sac deformity, Hill sac lesion. Thank you.